Good afternoon, everyone. And my innovative approach is on electrophysiological approaches in glaucoma. I always wondered what is the feasibility of this tool in current glaucoma practice. We know that in established glaucoma, we don't need electrophysiology. It's not mandatory because fields do the job. But have you ever pondered as to what happens in the advanced glaucoma patients who are elderly? Can they sit for how comfortable they are with fields? In such cases, we can consider electrophysiology. So also in the glaucoma suspects, ocular hypertensives, and early glaucoma who have equivocal ambiguous fields, not typical early field defects, are actually dilemma patients in clinical glaucoma practice. Always the clinician finds it difficult, and they are in a dilemma whether to treat this patient or not. And each individual clinician has one's own regimen. Like for example, if a patient has a good notch with a typical notch with a wedge defect and a raised intraocular pressure, obviously the dictum is to treat. And on the other hand, if you have a good notch but you have a normal IOP, you itch to probably investigate today to be safe. And if you get a thin cornea or if you get an OCT defect, then you probably end up treating. What I mean to say is glaucoma suspects today are overtreated, and glaucomologists are aiming to reduce this overtreatment by documented evidence with corroborative tools. Look at this patient with the inferior notch in the left eye. She has a corresponding inferotemporal wedge defect and a white-on-white perimetry, which is normal. So it is this pre-perimetric glaucoma group which I got a chance and opportunity to explore with the installation of the visual electrophysiological system, the Roland Consult, at our institute in 2010. These are all the tests which can be done by this device, and I have highlighted those which are important in glaucoma, the pattern ERG and the visual evoked potential. But I would like to put a word on the photopic flash ERG, which actually only delineates is derived from the photoreceptors in the bipolar cells and is important to the retina specialist for outer retinal disorders. But there is a component of the photopic flash, as you can see, the negative wave after the B wave, the amplitude of which is gaining popularity as a newer modality to detect early glaucoma. The modifications of VEP, the multifocal and the S-cone, that is the blue-yellow, VEP is more sensitive, but multifocal ERG doesn't have much of a role. Coming to the pattern ERG, all literature searches tell you that because N95 wave, the N95 wave actually is the hallmark for detecting the dysfunction of the retinal ganglion cell. So it is the N95 latency and the amplitude which are important measurements. And it is the tool for all detection of pathologies of the inner retina. This is to show you the electrode placements as per the ICSEV guidelines, international guidelines, where you can see the active DTL electrode being placed, the reference electrodes just next to the ipsilateral canthi, and the ground electrode. It's very important to scrub and place the electrodes with a conductive gel in a proper manner. It's a binocular test. You can see the patient visualizing the monitor where you have the reversing checkerboard pattern stimulus with the average luminance kept constant. In our machine, we had the option of the large checks and the small checks, and Professor Back in his published article has come up with this important finding that the pattern ERG response to the small check size of 0.8 degrees is affected in early glaucoma, while large stimulus checks are relatively normal in early glaucoma, and thereby came up to this paradigm of pattern ERG ratio, which was incorporated in our machine and which I could explore on my patients after categorizing them into early, advanced, and normal controls. They all underwent electrophysiological evaluation with pupils undilated, and we analyzed the N95 wave. A lot of in the individual itself, you can have a lot of variability in the amplitude measurements because it's such a difficult, sensitive test with small voltage amplitudes. So the ratios probably do better. The N95 P50 ratio, we measured them and we did a comparative pair t-test across the groups, and we found that the N95 component is reduced in early glaucoma, as well as the mean of the N95 P50 ratio is also reduced in early glaucoma. If you look at the amplitude response, differential response to the small and the large checks, as you can see the red line, you can see a steep slope which shows that it is a good decline, and so it is sensitive for early detection. And the pattern ERG ratio of less than 1 in early glaucoma, we got in our study group to about 92% of patients. Does VEP have a role? How can VEP have a role when you have an electrode placed over the occipital cortex, and basically VEP actually tests the functional integrity of the visual pathway? I've always wondered how can we come to conclusions with that to practical glaucoma? This is to just show you where the active electrode is placed just above the occipital protuberance. And this is the wave component, of which I would like to emphasize that the P100 wave measurements are the most important, the amplitude and the latency. And this is a recording. It is a monoocular recording where you can see the forehead, on the forehead, the ground electrode, and over the, just above the occipital protuberance, you have the active electrode. And here again in our instrument, we have the advantage of having two check sizes, 1 degree large checks, and just below you can see the small check sizes. Patient looks at the red cross and you can see the repetitive stimuli evoking the response. And after observing the results, actually I did a consistent study in the last 6 months categorizing my glaucoma suspects clinically into low risk and moderate risk. Those who had a moderate to large risk were put in one group, and the low risk. And we found that in 62.5% of glaucoma suspects, we had a differential response to the small check size in P100 latency. This was an alarming important finding. And in those patients, we had again a pattern ERG ratio less than 1. We had 68.8% of suspects having a ratio of less than 1. If you compare those patients who had other eye normal, affected eye definitely had a lower amplitude. And all this was validated in the studies published as well. But there are no real publications on the differential response with small check size in pattern VEP. I'll show you clinical scenarios. In this patient of mine actually had in the right eye a typical wedge, left probably clinically normal, but OCT showing you attenuation in both eyes. And look at the pattern VEP. I'll just touch upon it. Like on this side, you have the large checks and the small checks here. This is for the right eye, and there's the left eye, and you have important one, the latencies. If they go above normal, it is marked in asterisks, with an exclamation mark. And this P100 latency and the P100 amplitude are the important parameters in the VEP. VEP, as I told you earlier, this particular patient, please look at the 15-minute response, that is to small check sizes. It is prolonged in both eyes. It's prolonged in this as well as this. So it's an important finding. The left eye, which we thought was clinically normal but gave you an OCT RNFL defect, had a latency prolongation to small checks. And the pattern ERG ratio was showing an asterisk for the N95 waves in the right eye. That means the stronger risk patient had an N95 latency, and the ratio, as we can see in the right eye, is below 1. So left eye is considered normal from this aspect. So patient who looks clinically normal, our small check size in the pattern VEP is picking it up as a probable person to be instituted on treatment. The second patient actually is a myope with tilted disc and inferior rim thinning in the left eye with a borderline pressure. Clinically, because you have a borderline pressure in one eye, everybody ends up treating the other eye. But now we have evidence, and let's have a look at the P100 latencies. And you find that 15-minute, that means the small check size even in the other eye, that is the right eye, it is prolonged. And look at the amplitudes. The N95 latencies are prolonged in both eyes, which is an important finding again. It's got an exclamation mark in both eyes. The ratio also is less than 1 in both eyes. So the evidence is for treatment. The third case, again, an early glaucoma suspect in both eyes, probably an early superior notch. And look at the OCT, it also is flagging it as red bipolar. What does the ratio tell you? It tells you that it is less than 1 in both eyes. And what I want to say is the glaucoma suspect rate increases more than latency, the amplitude reduction becomes important, because the left eye is more glaucomatous and we find amplitude reduction in the left eye in the ERG. And so also the VEP. The fourth case, here again, the left is considered normal. The patient had glaucoma suspicion in the right eye. And here I would like to emphasize, look at the right eye wave amplitudes. And the pattern ERG is also wave amplitudes. The ratio less than 1 in the right eye, but normal above 1 in the left. The fifth case is I picked up a patient with moderate glaucoma with superior field defects and typical disc changes. Such a patient, again, I would like to emphasize that OCT does pick up, and we find that the pattern VEP more than the P100 latency. It is the amplitude that becomes more important. So also the amplitude gets lesser in the pattern ERG wave as the glaucoma becomes more established, with the ratios obviously less than 1 in both eyes. So when we did both conjunction of VEP and pattern ERG with pattern ERG ratio, all of it put together on the high risk or on glaucoma suspects, probably we have more evidence to narrow down to which patient to treat. But all the same, finally, you have to go clinically. You can't just believe in tools. But if P100 latency prolongation to small check size can be considered as a marker, if along with it you have a decrease in the VEP in the P100 amplitude, it becomes a strong indicator. And if along with that you have a ratio less than 1 with an N95 latency prolongation, it becomes again an additive marker. And this differential decrease to check sizes I have not observed, but literature search has shown me that Professor Mark Latina in the new equipment, Diopsis Home Office, VEP and pattern ERG, they have an inbuilt contrast difference, and the low contrast, which simulates the magnocellular pathway and picks up early detection, is the basis for their compilation of using it as a tool for treating, for detecting those who are at risk for progression.